Okay, so I think we'll go ahead and get started.
Yeah,
Thank you everyone for joining us for the Division of Rheumatology Grand Rounds. I just wanted to make a couple notes that the panelists cannot see or hear your video or audio. So in order to ask any questions for Dr. McMullen during his lecture, you can just use the Q&A box that you'll see at the bottom of your screen, and he'll save about 10 minutes at the end of the lecture to answer your questions. And now I'm just going to pass things off to Dr. Kennedy Ukarike.
good morning, everyone, and thank you for coming to Grand Rounds today. So I have the pleasure of introducing our speaker, Dr. Christopher McMullen, who is with the Department of Rehabilitation, Physical Medicine and Rehabilitation here at University of Washington. So just a brief background before we get started. Dr. McMullen earned his MD from University of Maryland School of Medicine in Baltimore, followed by a transitional medicine internship before completing his residency in physical medicine and rehabilitation at University of Colorado in Aurora. He then served as a chief resident before coming to UW to complete his fellowship in sports medicine. He is currently a clinical assistant professor in the Department of Rehabilitation Medicine and serves as a sports medicine attendant at the Husky Stadium, Harborview, and neighborhood clinics at South Lake Union. Since residency, through fellowship, and even presently, he has served in various capacities as a sports team physician, including for the Seattle Marathon and the Seattle Rock and Roll Marathon, for those who have participated in this before. He is a recipient of various awards in rehabilitation medicine, a fellow of the American Academy of Physical Medicine and Rehabilitation, and a member of the American College of Sports Medicine. He has authored and co-authored multiple peer-reviewed papers and a book chapter, and has given many lectures and presentations at local and national conferences in rehabilitation and sports medicine. So he's going to present on a really interesting and somewhat controversial topic, which I think it will be really helpful and really important for us rheumatologists to hear about the current state of affairs with regard to this therapy. So that said, I will hand over to Dr. McMullen, and thank you again.
Great. Thank you so much. That's too kind. Appreciate it. I really appreciate having the opportunity to talk to you folks today. It's a little bit intimidating to talk to a group of rheumatologists about arthritis, but hopefully I bring a slightly different angle, bring my approach as far as sports medicine and rehab approach to treating these patients, and specifically want to talk a bit about platelet-rich plasma, or PRP, and its use as therapy in treating these patients. So I will go ahead and dive in, and as was mentioned, I'll save some time at the end for questions. So if you have them, we'll be able to go through them then. So just want to start with a case that is familiar to all of us in our clinics. And so this would be a very typical patient that I might see. 65-year-old who comes in with progressive knee pain over the past 8 months or so, really worsened in the past couple of months. In general, he's fairly active, walks 1.5 miles daily. But over the past month or so has had to stop that activity because the knee pain has gotten to a point where he just can't do that anymore. On further exam and conversation with him, the knee pain sort of localizes to the joint line, worse with walking and standing. So you kind of have a good sense of what this could be, and you obtain some x-rays, and they sort of confirm your suspicion that this gentleman may be suffering from osteoarthritis in the knee, and has characteristic findings on an x-ray that you decide to obtain. So this diagnosis is not necessarily that complicated. It's something that is exceedingly common. But the trickier part is, how do we manage this patient going forward? What do we recommend? And what are the options available? The burden of osteoarthritis is obviously massive, highly prevalent globally. It's a leading cause of disability. There's a significant impact on comorbid conditions as well. So we know that those with osteoarthritis are actually at an increased risk of dying prematurely. There's a high economic burden as well. Billions of dollars go into the management and treatment of this disease, and that is only expected to increase as our population ages. I think most notably is that there is no known treatment that is proven to stop this progression. We have things to help manage symptoms, which we will talk about. We have joint replacement surgeries, but can we really slow or stop the progression to date? That question is no or unproven. So what's the pathogenesis of osteoarthritis? Well, classically, we have this description of wear and tear. I know I've used that phrase in the past, and it's something you see commonly, and patients will often sort of bring that to us. But we want to move away from this, and this is a phrase that I try to avoid now for multiple reasons, but the main being that it frankly probably isn't that accurate. We know that osteoarthritis is much more than just simply a mechanical condition. And this is a complex condition that involves the entire joint. The cartilage, the subchondral bone, the synovium, the joint fluid all play a role in the development of osteoarthritis. I've had it described as trying to think of the knee or other joints as an organ itself. And so, it has its own biochemical makeup, and it interplays with other organ systems. And so more complex than simply wear and tear. I won't dive into too much detail, but how do we think this occurs and changes over time? Likely there is some trigger, either chemical or mechanical, that sets off this cascade of events that ultimately results in osteoarthritis and progression. A small trigger might result in a change in knee loading patterns. And this change in loading patterns is not necessarily something that is conscious or due to pain. This is likely felt long before the patient is experiencing pain. Those subtle changes may then result in activated chondrocytes, which then produce inflammatory cytokines and matrix-degrading enzymes. These cytokines and enzymes will then travel within the joint fluid, and that in turn can lead to synovitis and further production of these inflammatory mediators. That can result in cartilage degradation, and it's sort of a cycle unto itself at that point. The more as cartilage is lost, the underlying subchondral bone becomes more exposed to mechanical forces. And this mechanical stimulation of the subchondral bone can then activate osteoblasts, which result in further release of cytokines and these matrix-degrading enzymes. On top of that, we think there's probably a systemic transfer of inflammatory mediators as well. For instance, we know that adipose tissue can produce these cytokines and other inflammatory mediators that then circulate through the system and can make their way into the joint. As an example, we know that hand osteoarthritis is much more prevalent in obese individuals. That obviously is not due to mechanical factors, but is related, we think, to this systemic transfer of inflammatory mediators. So looking at the level of the cartilage, if you look at this figure C there, regular cartilage is going to have these tightly packed chondrocytes that are well organized and linear in structure, with a clear delineation to the underlying subchondral bone. As you get cartilage breakdown, you have fissuring in the cartilage. You have chondrocytes that begin to cluster and hypertrophy. And you have this loss of delineation between the cartilage and underlying subchondral bone. You have vascular invasion as well. On a more macroscopic level, we see this resulting in bone remodeling, cartilage breakdown, as well as some classic findings that we may see on X-ray. And so as this progresses, you can see cyst formation, sclerosis, osteophyte formation, joint space narrowing. In addition, you can also, on other modalities such as an MRI, may pick up on synovial thickening, underlying meniscal injury. This is all part of the same process. The natural history, the progression over of this over time, again, we think probably there is some triggering event that initiates the disease process. There may be some age-related and cellular tissue changes that occur. I'll point out that knee pain doesn't begin till more than halfway through this process. So likely there are underlying changes that we're not aware of or haven't picked up on, that the patient isn't aware of because they have no symptoms at that point. But likely there are early biomarkers either within the synovial fluid or the serum that may be clues that an osteoarthritis is beginning. On MRI, we might pick up on structural changes that we wouldn't see on X-ray, such as changes within the cartilage or subchondral bone or within the synovium. And then, of course, later, generally as a patient is beginning to report symptoms, we might start to see these X-ray findings again. Joint space narrowing, sclerosis, osteophyte formation. And ultimately that progresses into sort of end-stage disease where you have complete joint space loss and cartilage loss. So how do we manage this? You know, what are the tools that we use? Well, there's activity modification, which is do the thing that hurts less, right? Patients don't generally want to go this approach, you know, like our gentlemen, they may want to continue walking, doing the things they like to do. So that can only sort of work to a degree. Exercise and physical therapy, which are extremely important modalities, treatments for osteoarthritis. They are proven to work and have essentially no side effects, right? Exercise and physical therapy is probably what we should harp on most with our patients with osteoarthritis. Part of the reason that I avoid the term wear and tear is because that sets up this idea that if the patient exercises more, they're going to make their disease course worse. And that's actually not the case. And more studies are coming out that show that even in say runners or extreme marathoners, they don't necessarily have rates of osteoarthritis higher than the general population. In fact, they may be somewhat protected. So I always strongly encourage exercise and physical therapy. Physical therapy, our hope there is that we are building strength through the hips, through the quads. We are correcting abnormal loading patterns that may load certain aspects of the joint more than others. And you can really make strides here, but it does take a big commitment on the patient's part. Often I feel like we are seeing patients after they've tried these things and felt them to be unsuccessful. Often what we hear is that it didn't work at all, or it was too painful to do. They couldn't exercise because the knee hurt or the joint hurt. Moving beyond that, we have assistive devices, things like braces, canes, walkers, which work to try to offload the knee. These have some potential benefit, but often are felt by the patient to be uncomfortable, and they don't want to use them, right? Medications like NSAIDs are often a treatment we go to, but of course medications have long-term side effects that can be problematic. Surgery is sort of the end pathway of this, a joint replacement, but often patients don't want surgery, or they're young, and that it doesn't seem the best option. So we find ourselves very frequently in this realm of injections. Can we inject something into the joint that provides more sustained relief? And classically, that has been with corticosteroid, and it does work. Corticosteroid injections relieve pain, but the effects are short term, maybe 4 weeks. And of course, that varies among patients. Some feel like they get much longer relief than that, and others not. But that's kind of what we're left with. And unfortunately, what that sets up is temporary relief that then requires repeat injections over time. And repetitive steroid injections have been shown to have consequences, which we'll get into a bit later. Before I go on, it would be a mistake for me as a sports medicine and rehab doctor to not just present this resource. So again, exercise is what we should be harping on with these patients. This is a website, exerciserx.org. This was created by the Sports Institute at the University of Washington. It is a fantastic resource for patients to find places where they can exercise, classes, and other resources. You can search a zip code in the King County area, and it'll bring up all the resources available. You can add filters that filter for cost and that sort of thing, in case there are barriers. And so usually using this resource, I can find something for patients. So I just wanted to give you that before going on. So corticosteroids, as we talked about, are classically what we've used to treat symptoms from osteoarthritis. They work by interrupting this inflammatory cascade, and interrupting how inflammatory cells work within the joint. But as mentioned, there are potential downsides. So I'm sure a lot of you are familiar with this study that came out about a year ago, which looked at steroid versus saline injections every 12 weeks over a couple of years, and looked at MRI findings before and after. And they found in the steroid group, there was more rapid progression of cartilage loss than in the saline group, the control. Now, the clinical significance of 0.11 millimeter change in cartilage thickness, I think, is up for debate, but it is notable, and it's certainly something that we should be thinking about if we are doing these injections repetitively. This paper came out more recently as well, and actually got picked up in the media. I've had a couple patients bring it up. This group looked at intra-articular steroid injections and the potential adverse outcomes, and essentially identified 4 areas, 4 major findings that these can cause accelerated OA progression, subchondral insufficiency fractures, osteonecrosis, and rapid joint destruction. So these more severe side effects or consequences of steroid injections are probably rare, but potentially underreported. And it's something, again, that we should be thinking about. Outside of steroid, we sometimes turn to hyaluronic acid or viscose supplementation. This has been studied substantially over the past decade. It unfortunately probably does not work as well as we once thought it did. This review from the American College of Rheumatology, it was a position statement that came out earlier this year. And they said intra-articular hyaluronic acid injections are conditionally recommended against in patients with knee or first CMC joint OA, and strongly recommended against in patients with hip OA. And that's because these just haven't shown, this injection has not shown consistent benefit over placebo. And the studies that have a lot of bias. And so this is a treatment that I have turned to less and less over the past several years. And as a result, insurance companies, of course, are not covering this treatment as much as they used to. So with all of that, that kind of brings us to what other options are there. And that's where platelet-rich plasma comes in. Could this be a different injection option that is available to treat osteoarthritis? What's the evidence, and what's it doing for us? So first off, what is it? What is PRP? In the most strict sense, PRP is an autologous blood sample with a concentration of platelets above the physiologic baseline. Within that definition, different variations and forms of PRP can exist. That has been one of the difficulties with studying this and figuring out its exact effects, because not all PRP is made the same. But all PRP seems to fit within this very sort of basic definition. Where did this come from? Well, PRP has been used extensively in the veterinary community, specifically in horse racing. So this came about years ago as a treatment for tendinopathy in racehorses. Obviously, there is a lot of money in horse racing and keeping your horse going. And so it's an area where experimental treatments exist, and PRP was developed to treat various tendinopathies within these horses. And this ultimately transitioned to human studies, and classically PRP has been used for tendinopathy in humans. The data there is mixed, and I won't go fully into it. Let's just say it's sort of up in the air, and there's not clear evidence for PRP treatment in a lot of tendinopathy. But from that, its use transitioned over to osteoarthritis, and could this be a treatment effective for joints? So why platelets? What are platelets doing? Platelets are involved in a number of different pathways within humans: tumor biology, hemostasis, antimicrobial function, healing, regeneration, and inflammation. And I want to focus on these 2 areas. So platelets play a role in both inflammation as well as healing and regeneration. And given the pathophysiology of osteoarthritis, there seems to be some promise here. So again, I don't want to get too into the weeds here, and I'm not going to pretend I'm an expert on diagrams like this. But within PRP, its anti-inflammatory effects are thought to derive from this mechanism. or potential anti-inflammatory effects, I should say. Where PRP contains a number of growth factors, one of those being hepatocyte growth factor, which is thought to work within cells to inhibit transcription of these inflammatory mediators. So through this process, there's a decrease in these matrix degradation enzymes and these pro-inflammatory cytokines. PRP is also theorized to have these regenerative properties, and that's mainly, again, due to a number of growth factors that are within platelets. In particular, I'll highlight FGF, or fibroblast growth factor, which is involved in tissue repair, cell growth, collagen production, hyaluronic acid production. And within a joint, this has potential benefits. If we're trying to counteract cartilage degradation, can this slow that process? So how do you make it? How do you get it? So PRP is it comes from whole blood. So you draw blood from the patient. That volume can vary depending on the system or the preparation you have in place, anywhere from 10 cc's to 60 cc's. And then generally there's kind of one of two methods. So first, the blood is spun on a centrifuge and separated into red blood cells, which collect in the bottom. And then this middle layer, which is called a buffy coat, and that consists of platelets and leukocytes in high concentration. And then above that, you have platelet poor plasma, so just the plasma sitting here. From this, you can go one of two directions. And so one would be to just take this top layer of the buffy coat, which is going to have most of your platelets. So that is taken, and the other portion is discarded, and then the platelets are suspended within the plasma. The other option would be to take all of the buffy coat, which contains platelets and leukocytes, and that is then suspended in the plasma. These two methods will create platelet poor plasma, and then leukocyte poor platelet-rich plasma, or leukocyte-rich platelet-rich plasma. So LPRP or PPRP. So I am going to pull up this video quickly, which highlights our system for how we, what we use. It's called the Cascade system. So I don't believe there's any sound with this, but I can kind of talk through. So essentially it comes with a kit that looks like this. It comes with a PRP collection tube through which blood is drawn through. And about 10 cc's of blood is collected into the tube. And then, and this is using at least a 22 gauge needle to collect the blood, because you don't want to disturb the platelets through the collection. The tube is inverted a couple of times, and then it is spun. And so it's put into the centrifuge and spun for 6 minutes. And this allows that separation of your red blood cells and your platelets. So this is a system which only requires one spin in 6 minutes, and that's because of this tube. So as it comes out, this is inverted a number of times, and you can see there the separation of the plasma and that middle buffy coat layer, which is collecting leukocyte poor platelets. So that sort of specialized filter within the tube allows you to get the leukocyte poor PRP. This is then transferred over to another bottle and mixed with an activating agent, which allows for some release of some of the growth factors from the platelets. So then this is inverted a number of times as well. This is sort of just done within clinic. And then we'll draw from the vial about 4 or 5 cc's of PRP. So that being shown here, they're showing leave a little air to assist with drawing it up. And that's sort of what the final product looks like. And then that will be injected. Let's see if we can get one last look at that. So that's kind of what the final product looks like, and then we inject that into the area in question. Okay. So this would be an example of an injection. We do a lot of these under ultrasound guidance. You don't necessarily have to. This is showing a knee joint done with ultrasound guidance from a lateral to medial approach in short axis to the suprapatellar recess. We use a 22 gauge needle to inject at a minimum. Again, smaller needle gauge might disrupt the platelets before they're injected. So does it work? Well, there's really 2 categories here, I think, for answering that question. 1, does it help reduce pain? And 2, are there any of these sort of regenerative effects? So a number of trials have looked at this in osteoarthritis, and from those trials, several systematic reviews have come out, and I'll focus on those. So this was a review done in the British Journal of Sports Medicine in 2015. At that time, there was 5 randomized controlled trials and 5 observational trials they looked at. And what they found was a general positive effect on pain reduction compared with a control. Those controls were somewhat variable, but overall there seemed to be a positive effect, which was limited to moderate in pain reduction versus placebo or hyaluronic acid. This was a review in 2017, which sort of compiled all these trials that had been done at that point. At the time, there were about 8 randomized controlled trials looking at osteoarthritis. 7 of these focused on knee OA. There was 1 trial on hip OA. Of these 8 trials, I should say these were the 8 positive trials. So these showed that there was a benefit of PRP on pain reduction and function. Versus, again, some type of control. A lot of them were against hyaluronic acid. There was 1 trial against normal saline. And then in the other group, there was 1 trial against just exercise. So 5 trials did not show benefit. So 8 for, sort of 5 that were neutral. Potentially some benefit in pain reduction, but not fully clear, kind of some results going both ways. Now, most of these compared against hyaluronic acid, and as we mentioned earlier, that might be problematic. Is hyaluronic acid better than placebo? That's really up in the air, and potentially not, but a lot of these compare against that and seem to show some benefit. One of the findings is that this is very safe. None of the trials reported any major adverse outcomes. There is some pain associated with the injection, but outside of that, there doesn't seem to be adverse events or anything major. One of the challenges that has come out in all of these trials is that, again, not all PRP is the same. There is a lot of variability in how these studies are done and what PRP is being used. So that could mean one versus multiple injections. So in some trials, it's a series of 3, and other trials, it's just a single injection. Is there this activating agent or not? Is it leukocyte rich or leukocyte poor? And what difference does that make? What's the overall platelet concentration? So again, if you just define this as PRP being a platelet concentration above that of whole blood, well, that can mean a lot of different things. Is it 2 times? Is it 10 times? How concentrated is it? And then what's the post-injection protocol? Is there a period of rest? Is this followed by physical therapy? What exactly is being done? So other trials have looked to answer some of these questions. Probably most notably has been this debate between leukocyte-rich or leukocyte-poor PRP. So this was another systematic review in 2015, which had included 6 randomized control trials and 3 observational studies. And what it found was that the leukocyte-poor PRP had improved outcomes compared to hyaluronic acid and placebo, but the leukocyte-rich PRP did not show statistical significance with improved outcomes. So potentially, leukocyte-poor might be superior in treating pain in these patients. There are several different theories as to why this is. Leukocytes, obviously involved in inflammatory processes and inflammatory cascade. And are you increasing inflammation with leukocyte injection? And that's eliminated when you use leukocyte-poor PRP. It's somewhat up in the air. This is a more recent systematic review looking at specifically PRP versus hyaluronic acid for knee OA. And fairly consistently, there does seem to be benefit with PRP versus hyaluronic acid. And this is in pain and function scores. And so this had, I think, around 8 trials. 4 of those trials, kind of shown at the top here, are looking at benefit up to 12 months. And there is sustained improvement in pain that does seem to be lasting. Other trials looked at a smaller time period, 3 to 6 months, and there also seems to be benefit. So this is fairly convincing that PRP does seem to have benefit over hyaluronic acid. This was a fairly well done systematic review. You can see the kind of risk of bias in various trials there, but overall showing favorability. I just wanted to key in on one specific trial here that compared to placebo to a saline injection. So this was done in 2016. They had 15 participants in each group. This was done with 3 weekly injections of leukocyte-poor PRP and in moderate patients with moderate osteoarthritis, or grade 2 to 3 on Kellgren-Lawrence grade. And you can see that there is sustained relief compared to placebo. Note this. Even with placebo, you get this potential reduction in pain over 2 weeks to 2 months, but it is more substantial in the PRP group, and it is sustained much longer here. So this is out to 12 months. I like to use this as a kind of time scale when I'm telling patients about what results they might expect. That benefit may not peak for 3 months, which is obviously very different than steroid. And so sometimes you have to wait a bit before you see more of the benefits. But I generally, with patients, I'm advising that I Hopefully we're seeing some change, some improvement at 4 to 6 weeks, but that peak benefit might not be for 3 months. What about other joints? So those systematic reviews were mostly looking at knee osteoarthritis. There hasn't been as much in other joints. This was a systematic review looking at foot and hand osteoarthritis. They had 4 randomized controlled trials. They concluded a favorable outcome to PRP, but you can see that effect size is fairly small. I saw a question come in, and let me see if I can just pull that up. How often do you repeat these injections? So typically I'm looking at seeing how far we can go. So I try not to consider repeating the injection until a minimum of 6 months, but often we're looking at a year or more. And so I wouldn't repeat it any sooner than 6 months, but you might consider it at that phase. I'm going to bring in another question here. So why do leukocyte pour if the goal is to promote inflammation to a degree? It's a really good question. I mean, I think this is debated, you know, leukocyte rich versus leukocyte poor. I don't have a good answer. It looks like from the trials that leukocyte poor seems to be a little bit better. Again, this may be that actually we don't necessarily want to promote that inflammatory cycle. We are looking to get the benefits from these various growth factors, but potentially the leukocyte-rich PRP is creating a robust inflammatory response that is maybe causing more pain at the in those initial weeks following the injection. So I think there remains a question there. Okay. So the next real question here is, well, what about regenerative properties? Does there seem to be some sort of benefit as far as regrowing cartilage or regenerating? So there have been a few studies that have looked at this, and this this one here was maybe sort of the most favorable. This came out fairly recently and looked at PRP in 2 groups, using PRP versus a control. And in the PRP group, there's about 21 in each group. The PRP group received leukocyte-rich PRP, so again, a difference here, with a concentration of platelets about 4 to 6 times normal. What they found, and they did 2 injections separated by 4 weeks, and this is an example of one of the MRIs that they had before and after, which suggested maybe there was some improvement in patellofemoral cartilage volume. Additionally, that they noticed the statistically significant improvement in synovitis, looking at MRIs before and after. So this is somewhat encouraging. If you look at the image here, you know, gray being thin slices of cartilage on the underside of the patella, and you see potentially some increased thickness in this area here. And then if you look at this kind of 3D reconstruction of the cartilage, looks to be more robust after PRP injection. So that is somewhat encouraging. It is just one study. Other studies have looked at this as well, and the results have been somewhat mixed. So here, this was a case series with mild osteoarthritis, kind of grade 0 to 2. This was leukocyte poor PRP and just 1 injection. And at 12 months, they found that 12 of the 15 cases that they had seen on MRI had no worsening of cartilage loss, and one person maybe had improvement. But those 12 looked about the same. They weren't necessarily better. However, if you compare this to a potential annual decrease of 4 to 6% of cartilage volume that can be expected in osteoarthritis, maybe this has slowed progression. Is the argument made. Again, a little up in the air. Lastly, I'll point out this trial, which looked again at kind of more mild osteoarthritis. Leukocyte poor PRP, again with a concentration about 3.9x. This was a big trial as far as these studies go. So they had about 100 patients and split them into a PRP group, an NSAID group, and a hyaluronic acid group. And they found no difference between groups in cartilage thickness between baseline and 52 weeks. So they did not see that improvement with PRP. It was similar across groups. Now, they did see pain improvement in the PRP group, but they just didn't see these the cartilage changes. So what does it all mean? To summarize a little bit, PRP is first and foremost safe. So it seems like there are not any major adverse events. We're earlier in studying this, but there does not seem to be necessarily long-term consequences to the joint. And so that is all good. It seems like it is probably better than hyaluronic acid for improved function and decreased pain. And we can see this relief last out to 12 months, which is encouraging. Leukocyte poor PRP may be better for than leukocyte rich PRP for pain and function. Those trials I just showed you on regeneration, that one trial with leukocyte rich PRP maybe showed this enhanced regeneration versus the other trials, which did not see as robust of an effect. But I think that it's sort of too early to tell there. Is there this regeneration? It's not something that I advertise to patients. I don't say, let's do this PRP because I want to regrow your cartilage. I don't think that's what we're seeing. Is there an ability to maybe slow the rate of progression? I think that's possible, but we still need kind of larger trials, more data to know for sure. Lastly, our protocols aren't set. So number of injections, concentration of platelets, post-injection rehab, it's all largely unknown. And so I'll go over here in a bit what our protocol is, but still a lot of questions to be answered. So what we do is one injection of leukocyte poor PRP. And the reason behind that, one, we use leukocyte poor because of that suggestion that maybe there's some benefit to pain and function. And we use one injection mainly because of the cost. So this is not a treatment that is covered by insurance as of now. There has been some headway. I think one insurance company is potentially covering PRP for tennis elbow at this point, but we're not seeing broad coverage for osteoarthritis at this point. So $600 is the out-of-pocket cost for a joint injection without ultrasound. If we use ultrasound, it's a $900 cost. I will do knee injections without ultrasound just because I can feel very confident I'm within the joint with palpation guidance most of the time. But other joints, we use ultrasound. We recommend no aspirin or NSAIDs 1 week prior and 2 weeks after the injection. We don't want to affect the platelet concentration or the platelet function. Before and after. That is not necessarily based on robust evidence. There have been a few small studies that have looked at this, but that's kind of general consensus among our providers. We recommend relative rest for 1 to 2 weeks following the injection, and then following that by kind of gradual rehab and increasing exercise. When we do these injections for lower extremity tendons, say for Achilles or patellar tendinopathy, we tend to be much more strict with our rest protocol. Often someone's in a boot for a short time period. They may be limited weight bearing up to 6 weeks, just because of the risk of tendon rupture, which would obviously be a very bad outcome. But with osteoarthritis, we don't necessarily have that concerns, and patients do well generally, becoming more active early on. So a patient can walk out of the clinic. There's not necessarily a weight bearing restriction. Again, there is some pain with the injection, but it's generally pretty well tolerated. Currently, we're doing these injections at Husky Stadium and the Eastside Specialty Clinic. We have been looking to expand our access to our South Lake Union Clinic and Harborview, but it's just kind of where we are right now. I've personally looked into various ways to get PRP at different sites that have access to labs. So if you need a kit, obviously there's a financial cost to that to get the centrifuge and the kits. But theoretically, you can make PRP with fairly standard lab techniques. The challenge becomes sort of standardization. Are you creating the same PRP every time? And are you using a standard method? So going back to our case, what would I do with this patient? Again, generally, my first steps, I am still, recommending strongly exercise, physical therapy. We want to get this person back to walking. I'm okay with them doing their daily walk. I wouldn't necessarily discourage that. Once we get their pain sort of a little better controlled, and that can be through gentle exercise, through physical therapy. If we get to a point where we're considering injections, I still, as my first injection, I would try a corticosteroid injection to see, maybe this is kind of a one-time flare-up, and after an injection, they do well for a long time. And so that's still sort of my go-to is I'll do one injection. But after one injection, if the effects wear off, that's when I bring up these other options like PRP. Obviously, cost is a big factor into whether they can pursue that treatment or not. But it is kind of something I bring up and discuss with the patient. I try to be objective with the data that I presented today, and not sell something that is going to cure their osteoarthritis, but may provide some longer term pain relief. Okay, thank you all very much. I'm going to pull up the Q&A here and see if I can go through some of these questions here. Okay. Would it make sense to try to identify which factors in PRP are therapeutically effective? Yeah, I think that would be great. If we could kind of isolate some of these growth factors or other aspects of PRP, and then see what is more effective. And I think part of this too is we might find that certain preparations or PRP are more effective in some than others. And so just taking the question of leukocyte rich versus leukocyte poor, there are probably phenotypes of osteoarthritis that may respond to one better than the other. And it's going to take understanding the underlying chemical makeup of the synovium, what biomarkers are involved, before we have a better understanding of that. And I know there are folks in this department who are doing that work. Have there been any studies comparing PRP versus pure plasma? Not to my knowledge. This would be like platelet poor plasma. That I'm not aware of. I want to say there have been some studies looking at platelet concentration. You know, a higher concentration of platelets, are there bigger effects? Those studies have been pretty minimal and still kind of questionable results. Instruction regarding the use of aspirin. So I think we kind of touched on that a little bit. So again, our protocol is to hold a week before and a couple weeks after. There's, you know, some patients, the risk of holding aspirin is not worth the benefit. Do you do the injection regardless? You know, I guess you could consider that, but I think there is some concern with how aspirin, the effects aspirin have on platelets. Okay, what about using saline wash platelets versus plasma with platelets? Again, I think that's a reasonable question. I'm not aware of any studies that have looked at comparing the two. Yeah, I think there is a question of could different preparations yield different results. The activating factor. So it's just bicarbonate. What is calcium bicarbonate? So it's just its role is, my understanding is, it allows the platelets to release these growth factors. And so that theoretically wants to be timed just prior to the injection. I don't know how much it really matters. There's arguments that without an activating factor after injection of the PRP, it would activate anyway. But that's the idea. Let's see. Oh, and then the anticoagulant plays a role in just a blood draw, having it not clot. Does the response to PRP depend on severity of OA? That's a good question. There have been some studies looking at the severity of OA and PRP effectiveness. It does seem that PRP tends to be more effective in more milder forms of osteoarthritis, so grades kind of 1 to 2 versus 3 to 4. Some of those studies would include patients up to grade 3. I can't think of any studies that were including patients with grade 4 OA. But yes, there does seem to be a trend similar to other injections or other treatments that milder osteoarthritis tends to respond better. Has anyone shown a delay in TKA in those who have had PRP as compared to placebo? I don't think so. I have not seen that yet. I think that would be a nice study to have in how it might guide insurance companies. If you could show that you are delaying total knee replacement with PRP injections, obviously there's a financial benefit to that. And so that is a study that would be worth having. I don't know that we have it yet. Let's see. Returning to PT, how to assess if the PT is adequate. Are there particular things the physical therapist should be doing, and any guidance on writing PT orders? So yeah, great question. With physical therapy, it's not sort of one thing is going to be right for everyone. What I'm looking for in physical therapy is a focus on active treatments, meaning strengthening, gait assessment, potentially gait retraining, versus passive modalities. So some people go to physical therapy and they get some stretches to do, they get some heat or some therapeutic ultrasound, and that's the extent of their treatment. And so the big thing is making sure, do you have a strengthening program that specifically is focusing on the quadriceps and the hip abductors? by strengthening the abductors and decreasing a knee valgus moment, so that tendency for the knee to dive in a valgus direction. If you can correct that through strengthening and gait retraining, you can reduce some of the forces, particularly on the medial joint, where osteoarthritis tends to be very common. And so those tend to be the areas I focus. Patellofemoral osteoarthritis it definitely seems to benefit from quad strengthening as well, often medial quad strengthening, because you want to try to keep that patella right in the patellar groove and prevent it from tracking laterally with activity. I do often try to be involved with the patient's rehab. And when I'm writing orders, I am asking for active strengthening exercises. I'm asking for a gait assessment. And I always encourage the PT to contact me with questions. And I like to follow up with the patient after they've done some PT as well, to make sure we're on the same page. Are there controlled trials on the effect of physical therapy? Yes, we have evidence that physical therapy is beneficial in pain and function. If this is referring to PRP versus PT, I think one of the trials did look at a comparison between like physical therapy and a TENS unit versus PRP, and there was not a difference seen between groups. But it was kind of a smaller study. Most ideal patient to refer for this. Someone who has, again, maybe on the more milder side of the osteoarthritis spectrum, someone with functional goals, someone who we are trying to delay a knee replacement in, would be best. And those folks can, if you're putting in a referral, you can put a referral into just sports and spine and specifically mention you're interested in PRP injection. And probably the best place to refer that would be either Husky Stadium or the East Side Clinic, so it would be directed right to them. Okay, it looks like this is the last one here, which I'll take. Is there something to the timing of PRP and its efficacy more effective in early OA? So yeah, we touched on that a little bit, or people with recurrent effusions. The effusion question, I don't know. That would be interesting to look at, but yes, it does seem to be more effective in early OA. Okay, thank you guys so much for all your questions and tuning in, and I appreciate it substantially. If there's anything else, that's my email on the screen right there. Please feel free to email me if anything else comes up. And yeah, thank you so much.
Thank you, Dr.
Chris.
McMullen.
Yeah, for sure.
Much appreciated. I think people are migrating over to the works in progress.
Yeah.
Very good.
Thanks so much. Lots of questions. Okay.
Yeah.
Bye.
Well, thank you guys. Yeah.
All right.